standing as the cultural vanguard of West Java, Indonesia, nourishing the intellectual life of the nation, working for the benefit of the global world. This is Universitas Padjadjaran. Inspired by the vision of the Asia-Africa Conference, attended by representatives of 24 countries, the establishment of the university was the realization of the vision of the cultural figures of West Java to found an institution of higher learning in the cosmopolitan city, to educate and set forth to society dedicated and qualified individuals. Today, UNPAD has broadened its wings to encompass various disciplines and multidisciplinary academic endeavors through the efforts of 16 faculties and 1 postgraduate school. To achieve its mission to build the capacity to adapt and innovate in the face of the rapid development of science and technology at the international level, UNPAD is determined to become the center of research and innovation for the good of the nation and the world by continuously nourishing research and developing technology to create innovations in various disciplines. Currently, 36,000 students are registered at UNPAD, and more than 200 international students are registered in different programs, degree and non-degree. As an effort to constantly improve the quality of education, Universitas Padjadjaran is supported by approximately 2,100 professional faculty members with reputable qualifications. To achieve the goals of its mission, UNPAD has also established notable research centers which demonstrate serious commitment to and focus on achievements in a number of strategic fields such as the Center for Sustainable Development Goal Studies, the Center for Environmental and Sustainability Sciences, the Academic Health System, the Center for the Digitalization and Development of Sundanese Culture, the Center for Innovation and Pharmaceutical Services, the Center for Nanotechnology and Graphene Research, to name a few. Equipped with a central science laboratory network and a science and technology complex in the Center for the Development of Science and Technology on the main campus, Universitas Padjadjaran has risen in its role as a leader in higher learning geared towards innovation. UNPAD also fosters collaboration with other institutions involving all stakeholders.
Universitas Padjadjaran commits in providing benefit and service for the good of humanity and the preservation of the environment. This is a great enterprise which cannot be done alone. UNPAD believes that in the spirit of collaboration, this vision may be achieved. We invite you who have the same vision, a good intention to care for human life and the environment all over the world, to work with us, build collaborations, create a better world together.
Universitas Padjadjaran grew out of the community and has made it its duty to give back not only in the form of the dissemination of knowledge and information, but also through socially responsible activities such as student fieldwork, community outreach programs, and action research seeking to make direct impact on the community. With its feet firmly grounded in the local communities and environment, UNPAD is also making great efforts to take steps towards internationalization. It offers special programs for international students to maintain its global network and make its strategic and reputable place on the world map of higher education. As a site for the personal development of young minds and bodies, UNPAD supports a wide variety of student activities. UNPAD also provides students with libraries with an extensive collection of books, periodicals, and study materials, comfortable dormitories, health and fitness services, free on-campus transportation, and other supporting facilities which UNPAD continuously upgrades and improves. While being committed internationally recognized quality research, UNPAD maintains also its dedication in preserving traditional cultures as the compass for all of UNPAD's activities on and off campus. As of now, UNPAD have set forth unto society 200,000 graduates in various fields of work, including strategic government sectors and crucial multinational industries. Works for the good of society, bringing innovations and sincere contributions to humanity. Universitas Pajajaran, the pride of West Java, working for the benefit of the global world.
Greetings from Transcendent 2021, massive open online course in Cleft, WIB, and Palate, held by Faculty of Dentistry, Universitas Pajajaran, collaborating with Smaltran and YPPCBL has been going on for a few weeks. My name is Alia. I'm a student from Faculty of Dentistry, Universitas Pajajaran. So I see that we come from different countries here, so I think it is appropriate for me to say good morning, good afternoon, and good evening for everyone here. Also, greetings to Dr. Alhassan Datti from Aminu Kano Teaching Hospital, Kano, Nigeria. Hello, doctor.
Good afternoon, everyone, and good morning, wherever you are. Pleased to be with you today.
It's nice to see you too, doctor. Thank you for being here, doc. It's been an honor, a pleasure, and we really appreciate your presence here. Also, we have Dr. Gigi Dian Maifara, specialized in oral maxillofacial surgeon, and she is also a lecturer of Faculty of Dentistry, Universitas Pajajaran, as our moderator today. Hello, doctor.
Hello, everyone. Hello, doctor. It's an honor for us to see you today. Many we want to talk about. Thank you very much.
Thank you.
Thank you, Dr. Dian, for being here with us. Also, lastly, greeting to all of the participants. Thank you for participating in this course, and thank you for attending these live discussion sessions. So, doctor, this week, the participants already learned about alveolar bone graft, cleft anesthesia, and about the topic of this course, common anesthetic complication from cleft surgery. And the last thing is post-OP nursing care for cleft patients. And for today's live discussion, we are going to discuss about common anesthetic complication arising from cleft surgery with Dr. Alhassan Datti. This live discussion will be separated into two sessions, which is the first session is Dr. Alhassan Datti will answer the question that have been filled out by the participant in the website, and the question will be presented on the screen. After that, the second session, we will accept two more questions. Maybe if there is more time, we can add more questions from the participant here. The participant can ask the question directly to Dr. Alhassan Datti, and the participant can write down the question. So don't forget to write down your name before the question. So, doctor, it is time for Dr. Dian and Dr. Alhassan Datti. Time is yours, Doc.
Thank you. Okay. Hello, Dr. Alhassan Datti. It's an honor for us to talk to you today. And so many questions comes up. And without further ado, we will start the question session immediately. Okay, here the first question. The first question is, what is the most severe complication you have ever encountered and how did you manage it? The question is from Farah Shakira Reza, student from Universitas of Pajajaran. Please, doctor.
Yeah, thank you very much. This is a very important question. The most severe complication I've ever encountered is laryngospasm. That is a narrowing of the airway during the surgery because of airway manipulation, which during cleft surgery, you should always be expecting that. But you should also take measures to prevent it or minimize its occurrence. But the most important thing is that to even recognize that such or at that time, laryngospasm as an or if you're a surgeon that because you're going to work, you're communicating well. On the you see a rise pressure on your machine from the normal of maybe 12, 35 centimeters, see a sudden in the airway.
I'm sorry,
reflected.
Doctor. I'm sorry, Dr. Datti. I think your voice is not really good. We cannot hear you clearly.
How about now?
Yeah, it's better. Please, Doctor.
Yeah, it's good now.
It's better now. Sorry, it's my earphone. Sorry, I'll go back again.
Okay, thank you.
Most common complication severe complication that I've ever encountered. It's not only one, but this is more important, laryngospasm. Now, laryngospasm is a serious complication. If you don't recognize it early and you don't manage it well, then you are likely to lose the patient. It will lead to increased morbidity or mortality. Now, when laryngospasm happens, you will see on your monitor that the airway pressure has gone up. Sudden rise from, say, if it's reading 15 centimeters of water and you see a sudden rise to about 27 or 30 centimeters of water. Now, the next thing you will see if you are using that monitor we call capnography, you will see a change in the pattern showing that there is an obstruction internally. So what you need to do, what I do, I quickly, you will also listen to the chest, all this within seconds. You will listen to the chest and you confirm that the air entry is poor to the chest and or there is other sounds. So you confirm that capnography showing that there is still, your tube is still in situ. And then what you need to do, first of all, you increase the flow of your oxygen. If you're given, say, 50%, you now move to 100% oxygen. Number two, if you're using the inhalational agent, if you're using isoflurane at that time, then you should switch off that one and go back to halothane because it's more potent. It is more potent to produce bronchodilation because all what you are doing now is trying to oxygenate and also try to open up the airways. So you will see a drop in the airway pressure, and then you will see the capnograph returning to normal. And of course, you may have your precordial stethoscope in situ and you're listening and the airway entry will improve. Now, sometimes that doesn't work. Okay, let me mention also, if you're using sevoflurane, I consider it to be like halothane and isoflurane in one. So it is also a potent bronchodilator. Now, if that is not effective or not enough, you can also nebulize, say, albuterol or salbutamol, all in an effort to bronchodilate the airway. So another measure you can do, if that doesn't work, then you now need to use suxamethenium. Now, suxamethenium is the one maybe you have used to facilitate intubation. If you have given that first dose, remember that a second dose, you must give atropine. Now, atropine is also a bronchodilator. So you give your atropine, you also give suxamethenium, because there will be relaxation, and then the bronchospasm will go. Now, why do you all do this? Because if you don't address this situation quickly, then the child or the patient will suffer from hypoxic brain damage. And then on and on post-operatively, you'll be battling to the ICU, and eventually, depending on the damage, the patient may die or have serious neurological complications. So this is how I manage. Number one, you don't panic. And you can, well, whether it doesn't happen every day, but you can prevent, you can minimize. The best thing is to try to minimize its occurrence. And that is why you can make it rare in your center where you practice. If you review your patient early and review the laboratory data, there are no evidence of airway infection. Patient is coughing. If it is elective, postpone the case until you treat the upper respiratory tract infection very well. And you can monitor that by using the laboratory data. You will see the WBC count. If you have eosinophilia, for example, you know that the airway is irritant. Now for cleft surgery, that is difficult. There is airway manipulation from the surgery, and you need to anesthetize your patient deeply. Okay, so if the anesthesia is light, then the patient is going to react. Remember that even if laboratory data shows everything is normal, at the back of your mind, you should know that this patient can have airway complications like this. And it can occur suddenly. But fortunately, if you are a vigilant anesthetist, you should look at the airway pressure, and you should also look at the capnograph if you have. Now, let me warn you that you should not rely on the pulse oximetry to say that you have laryngospasm, because the pulse oximeter is only displaying the amount of oxygen in the blood, not utilization. Now, when the obstruction happens, for a few minutes, it can still display normal. Whereas in actual fact, the damage is already been done. So you should rely on the airway pressure to look at it. It's going up. And then you have your precordial stethoscope. You are listening. You put one earpiece there and you're listening to the sound and also at the heartbeat. Now, if hypoxemia is there for some time, what you will hear is bradycardia. And then you know on and off to cardiac arrest. Now, cardiac arrest is the ultimate complication that you can have from that. So that is all I have to say now. I hope it is clear. If it is not clear, I can take it over again and explain in a very simple manner as I can. Thank you.
Thank you. Very clear explanation. And we hope we will never deal with that kind of complication, right?
Yeah.
Yeah. And maybe the first thing that we have to remember is don't panic, right?
Yeah.
Okay, thank you. And the next question. What can we do to reduce the complication risk if the patient has comorbid conditions such as anemia, URTI, and eosinophilia? It's from Raisha Aurelia Putri Lesmana, for a student from Universitas Pajajaran. Please, doctor, time is yours.
All right, thank you. This is another important question, which is linked to the last question we just discussed. And to to address the complication that I mentioned earlier, this is one of the things you do. Now, for anemia, you should know, first of all, let me be referring to the cleft patients, which majority of them are between the 6 months and 24 months. Now, you should know that the normal range of hemoglobin in children, it varies with age. From the neonatal period up to the first 2 months or so, the hemoglobin is high. For example, if it's supposed to be like 18 grams per deciliters, but by the time you are seeing something like 14, don't say it is normal because that is anemia in them. Now, but for cleft surgery, I know cleft lip, you don't do any repair until the patient is at least 3 months. So you check the range, 3 to 6 months, they have a different range. So when you check preoperatively, take your reference and look at it that it is within the range. Now, don't rely on the laboratory data like that. You must look at it with the clinical findings. So as a clinician, if you check the patient is pale, patient is pale. Patient can be pale and then there could be laboratory error reading normal hemoglobin. So patient is pale, is pale. So if it is below normal, then measures should be taken to correct the anemia because it's elective surgery. And the definition of elective surgery is that it is surgery that should be done at the time that suits the surgeon and the anesthetist, not the patient because it's not emergency. So you will correct the anemia. Now, it's also important to look at the cause of that anemia. For example, I've seen children where sometimes you order for the film. You will know the type of the anemia, whether it is nutritional, whether it is due to a kidney problem, and so it gives you a picture. For example, you can see a hypochromic normocytic, that is, the color of the red cells will change in the film, the report will come, and then the normal shape is there. But you look at this child, the child is malnourished, maybe coming from a very poor socioeconomic background. So, and alongside with it, don't forget that these children could have been exposed to hookworm infection, for example. Sometimes I treat empirically. I give them antihelminthic, get rid of the hookworm which sucks blood, and so on, and then anemia is corrected. So, and then don't forget about malaria. Malaria is endemic in our environment and I think in your region as well. So chronic repeated infection malaria can also have coupled with the nutritional things. So you need to look at all this and treat, and then anemia is corrected. Now, the other thing, the other comorbidity is upper respiratory tract infection, which is very common in these children and also in children being planned for cleft surgery. Now, you look at the signs, patients have a cough, and then the chest, you have chest signs, it's congested, sometimes leads to pneumonia, that should be treated. Now, if you look at the white blood cells count, you will see there will be neutrophilia, that is acute, showing acute infection, active infection. So you treat with antibiotics, or you refer the patient to the pediatrician or the medical officer who will now treat this infection, monitor properly, and then you review again. Then you will see that the clinical symptoms have greatly subsided, and then you look at the laboratory data again, and then you see these figures are within normal. Now, for cleft surgery, you must remember that I mentioned earlier that there is that element of possibility of reaction in the airway because their airway is hyperreactive. Even when the WBC count, everything is within normal range. I've seen that. So the most important thing is to be prepared with your drugs when such things happen from manipulations, then you can deal with it. Then eosinophilia Once you see that, don't do that surgery. Postpone it until you find out the cause of this eosinophilia. The eosinophilia signifies allergy, or there is upper respiratory tract infection and there is allergy. So you try to treat that until it is within normal limit. Now, if you go to the lowest level you can, and something that cannot completely go away, you have reduced that risk of airway complication. Of course, for example, in Smile Train, one of their protocol, you must have drugs to counter allergy. For example, hydrocortisone or dexamethasone, which you can give perioperatively to reduce what these drugs do is to stabilize the mast cells, which mediate this kind of reaction. When they are stabilized, then the reaction may not occur. When it comes, it will be mild and you'll be able to deal with it. So this is the much I can say on this.
Thank you very much. It's very clear. So you have to manage every comorbid condition until the patient is stable, and then you can do the surgery. Yeah. If they don't stable yet, so don't do the surgery. Right.
Yeah.
Thank you. Okay, we can go to the next question. Why does the timing of complication usually 44.7% happen at intubation? Well, please.
Yeah, interesting question. I don't know where the person asking this question got the figure, 44.7%. Maybe it's quoting a research or an article published to show the incidence of complications. Now, the one I had during my presentation last year in August, I cited an analysis done, I think, in India on cleft surgeries done over a period, and they reported about nearly 70% of the complications that occur is at intubation. Now, why at intubation? Like I said, intubation requires the anesthetist to do a laryngoscopy. When you do a laryngoscopy, you will now have to intubate. All this will trigger or will stimulate reaction from the airway. And then it will lead to release of histamine, which will cause airway reaction. And that is why you give these drugs, say dexamethasone, hydrocortisone, when you suspect this, to stabilize. The second thing is that the anesthetist, now this is from the patient side, you try not this thing to occur, or you try to minimize the occurrence of this. Now, the second thing, you will have to avoid drugs that will release histamine. For example, well, tipenton is minimal, but it can also release histamine. But you try to give, do inhalational induction using halothane, which is very potent at vasodilatation. And then you now give your muscle relaxant to facilitate endotracheal intubation. So the goal is that the patient must be deep enough to be able to facilitate intubation. The other thing is the skill of the anesthetist or the anesthesia provider, let me put it that way. You cannot be attempting to intubate like 2-3 times. Each time you touch the airway, you are triggering some reaction and the edema. And then with each attempt, then is going to, you're increasing the risk of this airway mishap at intubation. If you if you fly frequently, you will know it's just like in a flight, you have a takeoff and landing. You all know that takeoff and landing, these are the most important aspect of a flight. And they are the ones, all airway mishaps, they happen during that period. So it's the planning, the skill of the anesthetist, and then the drugs you use. So patient must be deeply anesthetized. You must give the right drugs, the right dosing, and then you intubate. And then when you intubate, you should know the drugs that will not release histamine. You should not give that. Thank you.
Thank you. Have you ever dealt with a condition that the edema has happened and then it's very difficult to do the intubation and you have to postpone the surgery? Have you ever dealt with that kind of condition?
Yes. When you are dealing with children, particularly for cleft surgery, because of the deformity, some of them can present with formidable challenge in terms of airway management. And that is why the skill of anesthetist is important here. And the skill you don't have to be a doctor, because we know we have anesthesia providers in the nursing cadre. It has to do with the experience, the years. If you are up to 2 years and you've been practicing well, this levels up, and then it's easier for this anesthetist to recognize and deal with it. Now, like I said, so algorithm for airway. There are, example, for cleft surgery, you have anticipated difficulty. We always say this is anticipated cleft. Number 2, although the differences with the adult is in neonatal and infant period. If you're dealing 8 months up to 12 months, you should normally, there could be difficult laryngoscopy being the.
Sorry,
right?
sorry, doctor.
So,
we cannot hear you clearly. Sorry. For the last 2 minutes, we cannot hear you clearly. Sorry, doctor.
Hear me now.
No, not yet. We cannot hear you. Sorry.
Clearly, can you hear?
You can try again.
Can you hear me now?
Yeah. It's good now. Thank you.
Sorry, we have to attention anytime. Let me start again quickly. Why does complication usually is high? Of the manipulation, way, the instrumentation, laryngoscopy using the that alone will trigger have anything, or a flash that you have. So it's the same thing to now put tracheal tube. That intubation must be, if the experience is likely more than once or twice or 3 times, and that can lead to even larynx. So it has to do with the skill of the anesthetist and then the condition of the patient, which if we prepare well, we'll have patient side. Now at intubation is purely the skill of the anesthetist. You have to recognize that these patients they are potentially difficult airway. And then with the cleft, this add to the challenge. Now, how you deal with that, you prepare what you call difficult airway tray. On the difficult airway tray, you have intubating aids. You have the stellate, which you put into the endotracheal tube to shape it in the way you want so that you can have an easy intubation. Number two, you must have a laryngeal mask appropriate size. You can have like 3 sizes, 1.5 to 2.5 size classic LME. Now, whenever you cannot intubate, the goal is to now oxygenate the patient. And then difficult to even ventilate via mask. So all you need to do is to try to insert the LMA, which sits over the 2 openings, the laryngeal opening and also the esophageal opening. So you ventilate, that way you will be able to oxygenate the patient. You can even give your inhalation and deepen the patient, and also now you can now try to intubate. So the main thing is to prepare the difficult air. It's nothing, any tray, just put the intubating aids. You will have different sets of blades of the laryngoscope. You have the stellate, and then you have the laryngeal mask airway. Now, that is all you need. Then you have your resuscitative drugs, like I mentioned earlier.
Thank you very much. Very clear, very bright explanation. Thank you, doctor. Okay, the next question. It's from Mutiara Az-Zahra, student from Universitas Pajajaran. What complications can cause a serious harm or disadvantage for cleft patients? Is there any way to prevent the complications from happening? Please, doctor.
Yeah, thank you very much. All these questions, they are extension of the other questions that have been addressed. For example, the complication that can is hypoxia. I mean, the end result of what was spasm or tube obstruction or disc, if there is hypoxia, it will lead to sometimes a cardiac arrest or serious neurologic problems that the child or the patient state if even you are able to resuscitate. Now, the way to prevent this happening, to make sure that we, both from the surgical side and also anesthesia side. And if you have a team working together, you develop minimum standard that you want to achieve. You have protocol that you follow in sequence. For example, your preparation, the patient should not be presented for surgery until the surgeons have deal with the comorbid conditions, which you can refer to the medical officer or the pediatrician. And even in some facilities, they have pediatric cardiologists, the respiratory physician. Then the anesthetist, when he comes to review, vet all this in and review again because condition can change. So in the end, the assessment these patients must fall within the 1 and ASA 2. Now, ASA means American Society of Anesthesiologists of Physical Status. It correlates well with the outcome of surgery. So a lens typically should fall within ASA 1 and 2. Now, ASA 1 is a normal healthy patient who does not have any obvious comorbid condition. ASA2, the patient has comorbid condition, but is well controlled, and there is nothing. The patient is seen by a doctor, and the patient say, no, I have asthma, or I'm a sick, so on. You will not know. So meaning there are no complications whatsoever. Or the hypertensive patient, his hypertensive is well controlled, but it does not have any dyspnea on exertion. There is nothing to show that this patient has any limitation. He can walk and run like any other person, okay? But if it is above 2, 3, then complications are there. They are obvious. They could be managed to bring the patient back to class 2, or they have to be contained for the patient to be stable. So when you prepare the patient well to make sure that the goal is to keep them within that ASA1 and ASA2 for elective surgery to be successful. So, and then the other thing, the anesthetist must adhere to standard protocol monitoring, and then able to deal with complication or anticipate these complications can occur. Now, you can have all the monitoring thing around you, but if you and deal with it, then you will not have a successful surgery. So the most important anesthetist is vigilance and the continuous presence of the anesthetist. For cleft surgery, because the airway is shared between the surgeon and the two are competing for space. Each one is putting its instruments and so on. Now, during cleft surgery, there is instrument they put to try to retractor to retract to keep the mouth open. That can impinge on the tube and lead to obstruction. Like I said earlier, you can detect using capnograph, but then there are tubes that you can use. They are non-kinkable. So those cannot be compressed. That is one. If you have the resources, you can order for those one and be using them. There are other special tubes like preformed tubes, which also does not kink easily, or you can position in such a way that this instrument may not compress on them. Then the other thing is that the most important thing is that the surgeon and the anesthetist must cooperate. There must be communication. You detect obstruction, you say, oh, sorry, sir, can you hold on a bit? Can you relax this retractor? So that you relieve the obstruction and you see things are coming back to normal, then you readjust. Because if you don't talk, hypoxia will set in. And then, like I mentioned earlier, it takes like a few minutes for it to be detected by pulse oximetry. Pulse oximetry is very important, but then there is that lag. But they early. Or if you don't have capnograph, you keep watching your airway pressure on the machine, which will suddenly rise. So adequate preparation, skill of the anesthetist, the ancillary equipment, the right instruments like laryngoscope. You cannot go and put ice blade when you need a smaller one. That's why you have a range of them. Then having a difficult airway tray, and then recognizing the fact that you are sharing the airway always with the surgeon and how to cooperate there, then you have to become friends at that point. And you must, just for the patient, and then if you're having problem, you communicate with us. And that is to avoid most of these complications.
Thank you very much. So the most important is preparation, and you have to anticipating every complication that maybe happen. Yeah, very, very clear, very bright explanation. Thank you very much, doctor. Okay, do we have another question?
That is the last question, doctor, from the website.
Okay, maybe we have any participant that want to ask the question directly?
Yeah.
So for the participant, now it's time for you to ask directly to Dr. Datti. You can click the raise hand feature, or maybe you can write down your question in the chat box. And don't forget to write your name.
Well, the explanation is very clear, very bright. So maybe the participant happy enough for the live discussion today.
You can also reach me any my the perspective that is all the patients. At any time, they can send questions like that, and we can always chat.
Thank you very much, Doctor. It's very kind of you.
Okay.
My pleasure.
Maybe you can also write down your contact in the chat box, maybe Dr. Datti, if the participant, maybe there is still another question later.
Okay.
Thank you very much, Dr. Datti. So I think that was the last question, maybe from Dr. Dian or Dr. Datti. Is that anything you want to tell for the closing?
Okay, please, Dr. Datti, maybe you have something to say to all of participants. And for me, it's a very glad opportunity to talk to you today, hear about all your experience, and with a very clear, very bright, very organized explanation that you gave. Thank you very much.
Maybe let me mention go. Can I?
I'm sorry, Dr. Datti, I cannot clearly hear you.
You hear me now?
Yeah, I can hear now.
Great. I important factor which has the drugs. It has to do with when they too tired, cannot walk up to. So the surgeon or the team, if the anesthetist, if he said, no, I'm okay, try to find a way, since it's elective, further surgery. If you have two anesthetists, them must not be tired. Imagine you have two pilots, so you must have one who is take proper decisions. Has happened to me, something. I have given narcotic analgesic before the baby comes out. And the baby came out floppy. I was trying to record my thing. I found out that I give atropine, but I gave pentazocine. And that's because but fortunately the baby survived. We do that. Many of these real. So to work when you are too tired. Thank you.
Thank you very much, Doctor.
Okay. Thank you very much, Dr. Datti and Dr. Dian. So I'm going to close today's live discussion. It was a great opportunity for all of us, hearing the valuable knowledge from Dr. Datti on this special occasion. And also thank you for Dr. Dian as our moderator today. In these hard times of the pandemic, we can still find the bright side, which is this online course. We can still learn from expertise around the world and through online. I believe that this will be an inspiration for all of us here to become a great doctor and implement it in our Cleft patients. For all the participants, please don't forget to join next live discussion in the It is in the Monday. You can check the website for the Zoom link. Before we end today's session, maybe we can take a picture, Doc, for all the participants. Please turn on the camera. I will help to count, and the committee will take the screenshot. So there is one slide. So for the participant, you can please turn on the camera. I will count. Okay, now 1, 2, cheese. Once again, 1, 2, cheese. Okay, thank you very much. Thank you so much, everyone, for attending today's live discussion. Goodbye and stay healthy.